So thank you to the organizers today for having me here. So my topic is clinical approach in vertigo. And this is my disclosure. I don't think I make money from here today, but my lectures I have given it before, especially in Abbott talks. So now, are we all ENT doctors here? Any neurology or medical? No. Okay, so how do they come to us, right? So there are two ways they can present to us, acutely or after they've had the symptoms for a while, right? So if it's acutely, they normally will turn up in ED or in primary care and GP, not so much as yet, right? If they have the symptoms after a while, they will still turn up in the GPs or primary care or in our clinic. In my center, I'm with KKM, Ministry of Health. So if they were to get an appointment to ENT clinic to see for a problem like dizziness and all, it is earliest is 6 weeks because my clinics are so busy. I think that applies to many KKM centers, right? So the difference here is that the urgency and the diagnosis we encounter is different in those settings, right? So where can we find more information? Google. That's the fastest, but you also must know how to Google properly. Now we have AI, right? Even in Google also got AI, right? Courses like this, right? So I congratulate you all for taking the time to come. It can be a very dry topic, but it's actually a topic where if you are successful in treating your patient, they are super grateful. All right, it's not something where you actually need to plan an op and then treat them. You can actually treat them on the spot. So that's the difference in, I find, AI in our audio vestibular. Conferences, such as the one that's coming up in APSCI. If you haven't registered, please register. We are also trying to see that if students who submit abstracts and they are accepted, maybe can get free registration. Yeah. So this is in November this year. The other thing, because we are all now into evidence-based medicine, please do your proper research. So for vestibular, there are actually societies, like Marani Society, which have already come up with diagnostic criteria. Okay. A lot of our vestibular conditions, patients who are dizzy, a lot of the diagnoses are all spelled out here already. Fulfill criteria, you have the diagnosis. If you've heard me speak before, I always say, please give them a diagnosis. If you do not have a diagnosis, you cannot treat them. Then they will come back again and again with the problems. All right. So how do we approach? If we have the diagnostic criteria, you need to ask your questions to see whether we can pluck out which is your diagnosis. Right? So it's so very important because spending the time to do it, you can actually get the diagnosis 80% of the time just in the clinic before touching the patient. Right? So you need to sit down comfortably with the patient and ask from the very beginning. So this is the latest algorithm, which we are also publishing with Abbott's. All right, it's meant for GPs, but I find that it's also very useful for us to organize our thoughts when we are asking our patients questions. Right. So a patient come to you, saya pening, I am dizzy. How many here have encountered patients who say saya pening? Can we show our hands? What is the meaning of pening? Huh? Dizzy. In Sungai Buloh, pening is sakit kepala yang tak teruk seperti sakit kepala yang teruk. Malah what? Fine, salah klinik, okay? You have to go to neuro clinic, bukan saya punya klinik. Alright, so history is so important. Then you always ask them after that, what do you mean by pening or what do you mean by dizzy? Okay, so from there then we can move on and say, is it really under vertigo or is it floating lightheaded imbalance? Alright, then from there your flow will actually change already. So are your symptoms your first time? Like say your first episode, have you had it before? Is it something which recurs? It means you have it, then you get better, then you have it, then you get better again. So from there you actually can have your flow down. Okay, so duration, how long is your episodes? Is it a few minutes? Is it with every movement? Is it when it comes, I cannot move, I have to go lie down and sleep? Right? Does it last 2-3 days? So all those will help you narrow down. Okay, so if it's in the minutes, then you're thinking maybe BPPV and it's positional. Is it So based on the diagnostic criteria, which I have already circled, vestibular migraine, they say 5 minutes to 3 days. Meniere's 20 minutes to 12 hours. Vestibular paroxysmia, less than 1 minute. Vestibular neuritis, up to 3 days, but you need to have at least 24 hours. So does labyrinthitis. So duration is important. Is your hearing affected? Right? So do you have reduced hearing? Do you have other symptoms like tinnitus? Okay, so not many things have hearing affected. Any triggers? This is where the history can actually take a little bit longer because you have so many other things to cover, right? If it's migraine, you're thinking, is it stress? Is it certain food? Is it the time of the month, right? The other things you need to check out and rule out, right? Is it blood pressure? Are you taking your medication? How's your sugar control, right? Any new medication you've been taking, right? So now, I find that a lot of us who have graduated, and then we go to our clinics and say, yes, I'm a surgeon now, I can do mastoids, I can do FAST. When the patient comes to you with dizziness, it's like, oh no, maybe the MOC lah. Correct? It happens, okay? So, I want to make it today as simple as possible. We're not going to make it very high-fi because I think your basics have to be strong before you can move on, right? So what kind of scenario gives you like, oh no, I don't want to see this patient, right? You first need to see it. The acute ones are amazingly quite easy to diagnose. Okay, so they are the ones who will call you from ED, nak refer ENT, patient pening, nak muntah-muntah, cannot get out of the bed. Everyone here understand Malay? Can, right? Can, okay. So the ones which gives you a little bit more headache is the chronic ones. Why? Because when it becomes chronic, it becomes overlap. You have multiple layers of problems already. You have decompensation problems, you have maladaptation problems. So, and then you can actually get more than one diagnosis. So that needs a little bit more time and patience. So, have you heard of acute vestibular syndrome? It is a name for something to mean that I don't know what is wrong yet. Okay. So patient come to you with new onset severe dizziness, super dizzy, vertiginous even. They are in the bed. They say that I cannot walk, I cannot get out of bed. And then when you examine the patient, there is nystagmus or gait unsteadiness. A lot of times, they call ambulance to take them to the hospital because it's something which suddenly hits them. Okay? What comes to mind? ED will call you, I want to refer for peripheral vertigo. Correct? In my head, is this a stroke? So these are the two things you need to know. Acute vestibular syndrome usually indicates, is it a stroke? Is it a peripheral vestibular? So when they refer ENT, what is their main purpose? To rule out peripheral vertigo. Always remember that. My job is, I must know my peripheral vertigo very well because you refer that to me. Okay? In the big world of the central and the neural one, that is really big role. It's important for you to make sure that you don't miss the important ones. But you as ENT, you must know what is peripheral vertigo. Okay? If there are any new neurological signs, facial palsy, cannot walk, unilateral weakness, indicate stroke first, tell them, please rule out a stroke first before calling you. Alright? Don't say send to clinic on Monday. No. Okay? They need to rule that out. And how you can rule that out quickly? Using hints. You all know hints? Yes, good. Now, I want you to look at the patient's eye and tell me what you'll see. Anything? You see nystagmus. Okay. What kind? It's a horizontal. What direction? Patient's left. Right? Normal, abnormal? Don't know yet. Okay. So, what is nystagmus? Nystagmus is a conjugate rhythmic involuntary oscillation of the eyes. You cannot control it, it just comes. Okay? It can be physiological, it can be pathological. Physiological, it can be when you gaze evoked. You're looking to your extreme ends, you get. How you differentiate it from a pathological and a physiological at gaze evoked? If you look very far end, you may get 2 to 3 beats, it will stop. If you bring your eye to the left and it goes very long, it doesn't stop, that's pathological. You go to the right, it looks to the right, that is also pathological. Alright, gaze changing. Just now, this is optokinetic. Can you see on the eye, the screen, the reflection? This is my son. I'm putting it in front of the laptop and say, look at the screen. And it comes on naturally. Alright, so this is physiological. Okay. If you have jerky movement or pendular, that is not nystagmus. Nystagmus must always have a fast phase and a slow phase. And you must always be able to tell, is this to the right, to the left, superior, inferior. Okay? If you have bilateral vestibular hypofunction, do you get nystagmus? You don't. Okay? Because both sides is dead. There is no asymmetry. So why does nystagmus occur? So this is going back to the basics, okay? I'm not going to talk about how this happens, but I want you to remember fact number 1. In our ear, in our inner ear, we have neurons, okay? And it's not something where if you trigger it, then it has spikes. We actually have resting spikes. That means at all time, there is a certain amount of energy in it, okay? If you stimulate it, like to say on my right ear, I have a certain amount of energy, I turn my head to the right, I stimulate it, it depolarizes and then it will trigger. Alright? If we hyperpolarize it, it will reduce the number of spikes. So at all times, there is a resting spike. There's always energy in it. Okay? Fact number 2. Okay? We have a pair. It's not only one. Alright, so what happens if I turn my head to the right, I stimulate the right, the opposite side is going to be hyperpolarized. It's going to be disinhibited. It's inhibited. Okay? So we have that balance. One side stimulate, the other side will go down. Fact number 2. If we have one side with a problem, okay, one side there is an insult, now your energy actually drops even when you're not moving. So this is when you have asymmetry. Okay, so what I like to tell my doctors is that always imagine I have a certain amount of energy here. If I have an insult on my left ear, this drops. I haven't stimulated my right side, but it is as if it's been stimulated all the time. Correct? I'm not moving, but this energy is up. So what happens when now I have an asymmetry? The first thing you will see is spontaneous nystagmus. Why? Because now this energy is higher. It's pushing my eye this way. And then my brain and my eye say, I cannot be sitting here, so it will keep going back to the center. Or try to go back to the center. So what do you see? Nystagmus. Okay? So when this occurs, what the nystagmus can tell you is, which is the stronger ear. Right? So nystagmus will point at the stronger ear, because now my level is higher here. I have vestibular neuritis on my left. This is stronger. Push my eye here. Nystagmus go this way. Everyone understand this? Okay. So always remember, nystagmus will point to the stronger ear. Because later we'll learn about labyrinthitis, and then we see, is it paralytic? Is it irritative? Right? Then you get confused. So just remember which ear is the stronger ear now. Okay. So nystagmus, I think you all know how to differentiate. All right. But remember, in peripheral vertigo, which I like, we obey command. We have rules which we stick to it. Nystagmus in peripheral vertigo, always one direction, usually horizontal with a torsional component. It will be inhibited by fixation, and it doesn't change with gaze. Meaning, if it's gonna, I have remember again, stronger ear on my right side, nystagmus this way, I look right, it will still be going to the right. I look left, it will still be going to the right, because it is the asymmetry. Okay, so it doesn't change with direction. At any time you see changing direction, it is not peripheral, call neuro. Okay? Now, I want you to look at the eyes and tell me what you see. So when looking in the center, you see some nystagmus. Can you see the eye being pushed? And then the nystagmus. Nystagmus to the?
To the right.
Okay, how many people say to the patient's right? Angkat. Kami say to the left. Kami say tak tahu. We see again, okay? I think got tak tahu, tak angkat tangan. We try again. So when we look, we also want to know the degree of the nystagmus, right? So if you look to the direction of the fast phase, this is a nystagmus to the right. Patient's right, right? So the right, you can even see the eye being pushed and then pop, push and pop. Very beautiful. So when looking in the center, we see the nystagmus, horizontal component. Just now when patient looked to the left, was there any?
No.
Center got. To the right, also got. To the left, no. So second degree. Okay? Now, the other thing which is in your ear, we have two things, right? When the balance goes off, when there's hypofunction, what happens? You see nystagmus. The other thing is now the function of vestibular ocular reflex is gone, right? If there's an insult. So you can actually test your inner ear function by doing a vestibular ocular reflex to look for it. Okay, so how do we do it? We do a head impulse. Alright, so when we do head impulse, what is your instruction? Tengok saya. Look at my nose. Okay, that's how I do it, okay? I say, look at my nose, always keep your eye on my nose, and I will trigger either to the patient's left ear or the right ear. Okay, so what happens in VOR is, it is a reflex. It's not something the patient consciously does, okay? If I turn my head, everyone turns their head quickly to the right, I stimulate my right ear, the velocity I move to the right, and the degree I move to the right is going to be expressed in my ear, my eye, in the opposite direction. It will always keep my eye in the center. So if I turn this way at 30 degrees, my eye will automatically turn to the left in the same amount of degree to the opposite direction. That is what VOR does, is to keep your eyes stable, facing forward, so that you can read your WhatsApp in the car. Okay? So, if you have a problem now, and my instruction was, tengok hidung saya. Okay? If my right ear is not working, I turn my head here, where will my eye go? Here. Nothing's pushing it. They say, oh, doctor kata tengok hidung dia. Then the eye will turn back here. So this moving here is called your corrective saccade. So if the patient has a corrective saccade, to the direction I stimulated the ear, that is the ear which has lost its VOR. That's the ear now not functioning that well. That is the ear with the lower function. So you can show the asymmetry that way. Okay? So if we go back again, nystagmus, fast phase will show the stronger ear. VOR will show you the loss. VOR will show the opposite side with the corrective saccade. Can you understand? We see the next case. Yeah? So remember just now patient had nystagmus on the right. Betul? Fast phase to the right. Where's the stronger ear?
Right.
Kanan. Everyone remember. Right ear is the stronger ear, okay? If I do VOR now, I do my head impulse test. Which side will have corrective saccade?
The left side.
Left side. Because left ear is the weaker ear. Okay? So have a look. Can you see? Very clear. See, the eye will automatically stay because if your VOR is functioning, it will stay in the center. Alright? So this tool will tell you this is a, okay, I went on to do skew. This is, I'm completing the hints test. Okay, no skew. So, okay now. So why we do hints? Because it's actually apparently proven to be more effective than doing MRI. So what I'm happy is my ED actually does hints test. Alright, so that cuts down some of the referrals to us. So peripheral is, this is actually mainly to look for vestibular neuritis. So hypofunction on one side. If you see a unilateral nystagmus, and you do a head impulse test, and there is abnormal, with a normal skew, that is peripheral. Okay. If you have bidirectional nystagmus, with a normal head impulse, if you're doing it correctly, usually at an acute period, okay, it usually means that both sides is symmetrical. So normally what I would say is bilaterally functioning normal. So I don't think it's a vestibular neuritis, okay, to stay safe. So this is the diagnostic criteria for vestibular neuritis. or acute unilateral vestibulopathy. Symptoms lasting at least 24 hours. Okay, they have severe vertigo. You see nystagmus. There is no hearing loss, no tinnitus. Okay, you do head impulse, you can find which side is the weaker side, right? And no central loss, and not accounted for by any other disease or disorder. Have you heard of Hinds Plus? No. So Hinds Plus is you must do with hearing test. If you don't have, you have no excuse, do Weber's. Bring your tuning fork. Okay. So if you have a patient coming to you with unilateral horizontal nystagmus, no gaze changing direction, and a head impulse which shows a corrective saccade, say, peripheral, Miss Karen say peripheral. But then when you test patient has hearing loss, that is central and tubular otherwise. If you have hearing loss together with a Hinds which looks like peripheral, it's central. Why? Because it's most likely a labyrinthine infarct or some other infarct lower down, which can present like a peripheral vertigo. So always ask about hearing. Don't be just happy at that level. Next, we got the basics already, okay? When you have asymmetry, you will have nystagmus. Nystagmus will point to the stronger ear. You do your head impulse, it will show you the weaker ear. That is good for your first 3 days. After that, what happens? In a normal patient who is young, active, not on medication, you will compensate. Okay. What happens when you compensate? After 3 days, nystagmus actually goes off in a vestibular neuritis, okay? If it's an acutely occurring thing. So they will say, I dah tak pening dah. Cik pening dah baik sikit, I boleh jalan pergi tandas, I have no more problems. You look in the eye and say, oh, I actually don't see nystagmus. Okay? How do we bring it back out? I want to know the diagnosis. So you remove the optic fixation. Optic fixation was the central compensation. How do you remove the optic fixation? Frenzel. How many here got Frenzel? No. My Frenzel size is 3,000 ringgit. Crazy, yeah? So a cheaper method is to shine light in the eye. Bring your handphone light. Everyone here got handphone? Okay, turn on the light, just shine in the eye. They will actually have problems fixating. You may be able to bring out the nystagmus again. Okay? The other thing you can do is head shake. When you shake it, you overwhelm the cerebellum in your velocity storage mechanism. That is like a what I call suspension. You can absorb shock absorbers. Okay, when you shake the head a lot, you can actually overwhelm that system. It can bring back out the nystagmus. Okay, and the mastoid vibration, all that is also part of overwhelming the system, so that your compensation actually tips over and then you bring out the original problem. Why do I want to do this? Because I want a diagnosis. Patient wants a diagnosis. I never ever want to hear patient say, Doktor cakap saya ada vertigo. It really, really irks me, okay? It's like saying, Doktor saya ada demam, itu penyakit demam. No, it's not a diagnosis. Vertigo is not a diagnosis. Okay? So, have a look at this patient. This patient was admitted in medical for stroke. Came into ED, severe vertigo, cannot walk. So they admitted for vertigo. For stroke. After 3 days, they say maybe it's not a stroke, let's call ENT. So we look at the eye, okay? First thing, always look at the eye. Spontaneous nystagmus, patient not moving. Okay, we have a look. Not so obvious. So what we do? We put Frenzel. Okay? Just now at the middle, second degree, we don't see anything. Now, we can see. Right? Horizontal nystagmus to which side? Patient's left. Okay? So, he has already started compensating, which is very good for him. Okay? Third degree, we don't see anything. Alright, so second degree, horizontal to the left. Which is the stronger ear? Left. Patient's left. Okay? So now we do head impulse. Which side will you expect to see? Opposite side, to the right. Can you see it? Yeah, because that was the only time I could catch it. After that, I can't catch anymore. Again, Right? So corrective saccade on the right. What's your diagnosis now? Right? Vestibular neuritis. Okay? Now, Another patient comes to you. She's had imbalance, no true vertigo. Refer to ENT for peripheral vertigo. What do you see? Nystagmus to the left when she's gazing to the left. And now? Direction changing nystagmus. When she looks up, she also has. Okay? When she looks down, she's also got some amount of facial palsy, right? Later we did a CT brain for a humongous tumor there, okay? So never send patients like that to ENT to route peripheral. This one ED could have seen it, the GP could have seen it, right? Okay. Now, in our ear, we talk about, we have different frequency hearing loss. We have high frequency, low frequency. In our balance system, we also have different frequencies. So now I'm throwing in more information because you are ENT. You need to know more than our GPs, okay? So in our ear, we can also measure different frequencies. Okay, so we have function to detect different frequencies. So in some patients, they may say, I have recovered, but I cannot sit in the car. I feel a bit dizzy when I'm in the car. Alright, so why? Because they may actually have problems in the low frequency. If they are walking, they are moving their head fast, they have no problems. So they haven't compensated at the level of the low frequencies. And how do we know that they have problems at different frequency? We can test it. Okay, so there are many tests which we can do for the vestibular system now. We have caloric tests. What do we test? It's the horizontal canal at the very low frequency. Okay, then we have the chair, which is at the low frequency to moderate. Then we have also our head impulse, video head impulse test, which is for high frequency. And then we have the vibration, which we do. Then a lot of times, actually, this is done by our dear audiologists. They have all this, and they can map it out for us. So it's very important. You can't do everything on your own, right? So you need to work. Now, as we go further and deeper, which may not be so necessary in the clinical setting if you're going back to KKM, but it gets me very excited. Okay, why? When we do the test, we can actually map out where is your injury. Okay, in my lab, I have video head impulse test. I have my VAMs. Okay, very minimal, but those is enough for me to map my whole inner ear already, my whole vestibular organ. How? Okay, so when we say vestibular neuritis, we got how many nerves? Superior and inferior vestibular nerve. And a lot of times, which is more common? Superior vestibular nerve. And what the superior vestibular nerve supply is like a map, okay? It's your upper two canals and your utricle, the upper half. So how can I test them? Okay, for my vestibular, superior vestibular nerve. I can test my superior or anterior canal and my horizontal canal using V-head. Okay, you may show there's problem that side. Then my utricle, I use OVAM. If I want to know is it an inferior vestibular nerve problem, then I can test my SACU using CVAM, and I may see V-head problem in my posterior semicircular canal. So patient, by the time I actually get a slot for this test, it may be already 2 weeks, 3 weeks, because time limitation, appointment slots per month. So patient actually, doctors say that okay, so but why am I still doing it? And then I can still see there are problems here. I can tell them, I can document the notes. You had a problem with this nerve, all right? So now you have a diagnosis, you can move on, right? So much better than sakit vertigo. Okay, so resolution, I say, with time, they will actually get better if they are moving, if they are not on sedative drugs, if they don't have other problems, or they are not too old, okay? So what signs loses its way with time, okay, if you see them later? First thing to go out is spontaneous nystagmus, right? Within 3 days, it is actually, you don't see it anymore. Unless your patient is the type who will not move at all, will hide under the blanket and really don't move at all, then they have no stimulation to compensate. Okay, but a lot of times they will get better within 3 days, 3 to a week lah. Head impulse will lose out within 1 to 3 months. SVV, which is your, I will show you what it is later, will resolve in 3 to 6 months, and caloric tests or head shake tests will go off within 6 to 12 months. Alright, so if your lab have this, you can actually still pick up any asymmetry, any hypofunctioning of the organs. So going back to how you approach patients with vertigo. In my center, we have assessment tools. There are many out in the market. Choose one which is validated and useful to you. Why is it useful? One, it will help you monitor the patient's condition, whether they're improving or not. Number two, if you want to publish papers, you want to research, you got lots of data there. So in my center, I use DHI, I use quality of life, EQ Friday, I use DAS. Why DAS? If you're dizzy long enough, you'll get very stressed and very anxious, and that will make you dizzy also. Alright, so we want to see what are the components contributing to your imbalance or your problems now. And then neck disability index. Because I noticed that a lot of patients with chronic dizziness, what happens after a while? They move like this. Okay? They're touching. Then when they sit, they go like that. Very stiff. Okay? So what happens is, with time, when this becomes very stiff, what is in your neck? You have mechanoreceptors which goes into your vestibular system also. So that persistent information which goes to the brain actually overwhelms the brain. And then you have this low-lying dizziness and discomfort when you're moving. Is it cervicogenic dizziness? No. By definition, cervicogenic, you must have an injury. Right? So a lot of these patients say, no, I don't have cervical spondylosis, I never had neck trauma, head trauma. So you can't call it cervicogenic dizziness, but you can treat it similarly with physio. Alright, so when I do NDI, that helps me target if you have any problems there now. Now, you have so much information in your head now, you have so many diagnoses in your head after taking your 1 hour history, you do examination to narrow down your diagnosis, like with any other conditions, okay? But we do targeted examination, I would suggest. So always check BP, heart rate, because it can still be symptomatic bradycardia or symptomatic hypertension, especially in ED, right? My advice is if they come to you in the clinic, take BP before you ask questions and do examination. A lot of time the BP will shoot up after they see me. So normally they sit down, I ask my nurse, ambil BP dulu, or if your center can take the BP outside, then do that first. So then there is this thing called postural hypotension. So just remember your SVP drop more than 20 or diastolic drop more than 10, that is postural hypertension. If they have tachycardia, you can also refer to your medical or cardio to make sure that it's not POTS syndrome with tachycardia, right? Heart, lung, examiner. Yeah. Look in the ear. How do you know patient don't have cholesteatoma eroded into your causing a fistula, right? So always look in the ear. That's why they send to ENT. Neurological examination. Make sure you're not missing out a stroke. What are the bedside vestibular assessments which you need to do? Nystagmus. Always do a spontaneous one first. Patient just sit there, eyes open, and then after that look left, right, up, down to look for spontaneous nystagmus. And then after that, do positional. Why? Because BPPV is still one of the most common cause of peripheral vertigo. Okay. Then the other things I check, I think this one, when you go for your courses, you will know how to do that. So, but we do Swift pursuit and Saccard to look for central, cerebellar for central, head impulse, head shake for peripheral, Fukuda, Romberg's, and DBA. The rest of it is for our vestibular. So this is on the foam. This one I want to show you. Patient says I have very, very bad dizziness. Okay, on the foam is already we are removing proprioception. Okay, and what we are doing? I'm asking him, 100 tolak 3, tolak 3, tolak 3. When you see he's frowning, he's thinking. He's trying to do the math. He will be very steady then. Right? He's no longer swaying already. Is he malingering? He's actually quite steady, right? Okay. So, a lot of times they say patient is malingering. What is definition of malingering? They want something out of it. That's an ulterior motive. That is by definition. I want to claim money or I want cuti, right? A lot of patients with chronic dizziness, they want to go back to work. They have no ulterior motive. They are imbalanced. Okay? That is called functional. His tests all normal. CT brain normal, vestibular test all normal, but he said, I am still so imbalanced. But when you do the test, you put him on the foam, you ask him to do cognitive tasks, he can actually become very steady after that. So it's the brain at that point of time which is working so hard to try and keep him balanced that he feels that he's not balanced. Okay, so functional is different than malingering. Patient's not malingering. Yeah? So other tests I do, subjective visual verticality. So in this test, you ask them to read the head moving. And then it is abnormal when you drop 2 lines. So if they can read without the head moving the last line, and then when they start moving the head, they cannot read anymore. No need to move the head so big, just small but 2 hertz. Okay, if you drop 2, you cannot read anymore, there is some vestibular problem. Okay, subjective visual verticality. I am with KKM, we are not rich, so we make our own. This is from Kedai Eco, RM2. Okay, bucket from there, and then we got a protractor, and then I tie a string here. So there is a line here, okay? So you need to actually put the bucket cover 80% of your view, and then you tell the patient, make it 2 lah. One is either most vertical or most horizontal. If you cannot get it be within 2 degrees of normal, that is also abnormal. 2 degrees. So just now was 2 lines, this is 2 degrees. Can do in your own clinic. Huh? Okay. So when they turn, they adjust, you will see it moving. Okay, I'm coming to the end already. BPPV. I think there are courses where it's just focused on BPPV because it's a really long topic. But I think you all know what is BPPV, right? It is crystals which has dropped out, or it's now in your semicircular canal. How many sets of semicircular canals do we have? 3. Which one most common canal? Posterior. Very good. So, unfortunately, it also can go into your other canals. Yeah. Which gets you excited now if you see a different kind of nystagmus. So BPPV, by definition, you must be triggered by a positional test. Alright? When they're sitting there, no nystagmus at all. When you put them in a different position, you will trigger a nystagmus. You must see a nystagmus. That is BPPV. Okay? And the nystagmus will stop. Why? Because it's crystal that is going according to gravity pull. So it will stop after a few seconds or under a minute by right. So you need to remember, if you need to take picture, this one. Okay? You need to know how to diagnose, what kind of position, what kind of test to put them in, and then you need to reposition them. Okay? Do you need to know more than one? Yes. Okay? Okay. All these now, there's so many YouTube videos. Don't watch TikTok. You can go YouTube and look at this. Learn it and practice it on your colleagues. Don't do it first time on a patient, so that you're familiar with the steps. Okay? So why? Because AIB, or American Institute of Balance, recommends that you better to know more than one type of maneuver, because you will test first. I say, oh, I see a rotational geotropic nystagmus on the right. So I say, okay, this is right posterior canal BPPV. So I diagnose with the positional test, and I reposition with Epley. Everyone likes Epley. So we do Epley. I say, okay. Then we test again, because we are confident. I say, we do again. I try. I say, I test again. I say, damn it, there's some more nystagmus. Okay, so we have to reposition again. I said, okay, I will try again. Let's do Epley again. This time we do slower, and at the end, I will shake a few times just to make sure everything drops down. Why we cannot clear the first time? Was it that you did wrongly? No. Sometimes the crystals have different weight. It's not just one crystal, it can be multiple crystals. Some are heavier, some are lighter. So maybe the first few have dropped off, you still have a few more which is lingering there. So the second time when you do it, hopefully everything goes through lah. So I say, alright, I will do Epley for you again. Patient say, okay, boleh lah, buat lah. So you do, oh, then you have vertiginous and all that. I say, boleh tak saya test sekali lagi? Tak mau lah. Let patient go home lah. Okay, go home, and then what you tell them? You have to keep moving, yeah. Keep hydrated, keep moving, okay? And then I'll see you back again. Hopefully it goes off. Because a lot of times BPPV after 6 weeks, it can actually dissolve, and if it's small enough, it can actually go off on its own. But it will disrupt them for the next 6 weeks. If the patient say, yes, I want to do one more time, are you going to do Epley again? No, please don't do Epley again, I'll do something else. Okay? So which is why it's good to know more than one maneuver. There are many maneuvers out there. Okay? So you do one more time. After third time, you send them home, because I got other patients waiting. Okay? So, yeah. So that's why you need to know a few, and always test after you do. At least twice. Okay? Now, I will conclude. Is it difficult? Alright. So the most common things which will come to you, I would say, is it a stroke? Is it acute vestibular neuritis? Now, living today, you should be able to tell which ear is the one which is hypofunctioning and which ear is stronger. Remember, nystagmus will point to the stronger ear. Your VHIT or your head impulse will point to the weaker ear. You have that two information, you know which is the vestibular neuritis ear already. Got hearing loss is a stroke. Any other thing which do not fulfill the criteria for a vestibular nystagmus, your peripheral nystagmus, is central and temporal otherwise. Okay, so just refer medical. Alright. BPPV, do we test on everyone? Yes. Why? One last note. As the patient grows older, especially in the elderly patients, I find that they do not come with true vertigo. They don't say, when I gantung baju, I rasa pening. No, they actually come with, saya rasa pening all the time. Right? So always do disulfide or I do Simon diagnostic on the elderly patients. Or even if patients say, I don't have true vertigo, I just have dizziness, just do it. Because a lot of times you will find that they actually have BPPV. Then by correcting it, they actually get better. Okay? So be systematic in your history taking, your examination, because now in your head you have so many tick boxes. Right? Examine to confirm your diagnosis. Then when you're unsure, read up, look up videos, everything now, how to diagnose the nystagmus, what are the type of nystagmus, what kind of maneuvers to do. Everything is in your palm. Right? So that is the time to do it. Okay, any questions? It's very basic. Oh, got question. Okay. Any questions? Yes, for BPPV, yes. Actually, even in acute vestibular neuritis, you will still be able to see it. Yes.
Okay, I have a second question. How about approach to patients with all the special group patients like pregnant ladies? They always sometimes they refer to ENT, and obviously you can't do disulfide on these patients. So we diagnose. What clinical tools can we use to assess these patients?
Okay, so when the patient, because now you're again you have to go back to your history, right? So if first thing you come to mengandung show pening kan? Yeah, but actually no, they do. I have had a few vestibular neuritis in a patient who is pregnant. So again, treat like any other vestibular patient. They come to you, take your history, and then look in their eyes and wait. All right. If the history, if you're lucky to catch it in the first 3 days, you may be able to see your nystagmus already. Then head impulse you can do in a pregnant lady, right? No problem. Frenzel's also can. Alright. So vestibular neuritis, I think you'll have no problem diagnosing now. It is, I think, BPPV you are talking about. So what I do is will do Simon diagnostic. Simon diagnostic is very, very easy. It's like your Brandarov first step, you know. Lie on your right shoulder, look up. So what I'm doing is my right ear now is lower down, and I will see a geotropic nystagmus. Nothing to do with the tummy. You just sit at the edge of the bed, just like that, sit. The leg can go. And then if I want to test the other side, just go to the other side. It is like your Brandarov first step. Okay. Then how to correct it? Do Simon. Can do. Okay. So there are many. Yeah. I think like a barbecue roll, all that, forget it lah. Huh? But if you're for horizontal, then you can do your Kurzer. Kurzer also is all sitting sideways. Right? So there are many ways. Please treat them. They're already so tired. Well, if you can treat it, then you treat it. So that's my specialty. You always give them appointment in the afternoon when you're not so busy, and they have to have at least 1 hour with you. Okay. So in your head now, chronic vestibularity is another whole chapter on its own. It's another whole lecture on its own. Alright, but the most common which I encounter after you rule out all your hypertension control or not, sugar control or not, medication all okay or not, is 3PD, persistent postural perceptual dizziness. They will present to you diagnostic criteria 5, right? They have no true vertigo. They feel dizzy all the time for at least 3 months, right? It's worse when they are standing up, when they're moving, or they're sitting, or they're exposed to carpet like this, or flickering light and a lot of movements. Okay, so busy visual stimuli makes them very uncomfortable. They cannot go to the mall, they cannot go to Maidin, gudang yang besar-besar, they cannot go places where there are a lot of people moving. Why? Let me just sideline it. Why this happens is because these patients now have visual dependence. They are using their eyes now to keep themselves balanced. So when there's so many things moving around, the brain cannot grab hold of something solid to keep them steady. So they feel very, very uncomfortable with lots of movement. So they feel dizzy all the time. Alright? So again, first one, chronic for at least 3 months, no true vertigo. Number 2, symptoms worse when they're upright, when they're moving, or when they're dizzy. Never a problem when they're lying down. So my question is, barring okay ka? Okay. So say, oh, maybe still TPD. The third criteria is they have history of acute vertigo in the beginning. Alright, it could have been vestibular neuritis, could have been admission for some penyakit, it could be a panic attack. Why panic attack? A lot of patients with anxiety, underlying anxiety, will have TPD. So they may have had panic attacks, then say, I'm okay already, or I had BPPV, I have vestibular neuritis. Sekarang dah tak pusing dah. Tapi dah 3 bulan ni, or 4 bulan ni, ada masa saya on the boat. Saya asyik floating je. Okay. Number 4, cause significant distress or functional disorder, loss. They cannot drive, they cannot go to work. They have seen many doctors. By the time they reach me, usually that's functional. I find that's already functional. You have to, somebody has referred them to reach me, right? The last one, no other diagnosis. Okay. And the good thing is, if you are an ENT center and a tertiary center, a lot of times CT brain MRI done. Nowadays, there are a lot of people who do vestibular testing outside, or come back, it could be normal. If it's at normal, it could have been because they had vestibular neuritis in the beginning. And that has resolved, and they are left with TPD. So how you treat TPD, you can Google in BENT, MEN therapy, under my name, and use it. So it actually involves 4 things. We want patient education. We need to, after you ask all your history, honestly, after 1 hour, the patient actually loves you because you sat down and you listen to them. That's really what they want. And then you tell them, okay, Puan or Tuan, you actually have TPD. Dia memang satu penyakit yang actually very, very common. It's like, I think in chronic dizziness, it is the most common cause for chronic dizziness in the adult age. Meaning you're supposed to be actively working, you are at your prime of your life, and now you cannot move. You cannot go out, you cannot drive. Right? It really demotivates the person. So when you actually give them a diagnosis, they are very happy and they will Google. I say, ya lah betul lah, saya ada TPD. Saya rasa lega sebab sekarang ada orang percaya yang saya ada masalah. Okay? Because unlike someone who has fractured their leg and you got a cast and say, I cannot work, when you're burning and say, I have nothing to prove that I cannot work. Okay? So give them a diagnosis, patient education. Why TPD occurs is because now there is maladaptation. You had an insult and your brain has used other senses to keep you balanced, using your eyes, you use postural control. So that is a maladaptation. Your body has not gone back to your norm. It's the new norm, which is not so good for the patient. And how we want to treat is, we want them to go back to having balance being monitored by your vestibular system. It's something which is now going to happen automatically. Balance is automatically, right? We don't think about it. But in 3BD patients, they are thinking about it. They are constantly thinking, am I balanced today? Is an attack coming today or not? Am I steady today? So when they scan and they ask, they are using their cognitive function, their brain, to actually keep them balanced, which is very tiring. At the end of the day, they say, my mata sangat penat, my leher sangat kejam, my otak tak boleh function, brain fog. Because now your brain has to keep you balanced, which you do not need to. Okay? Patient education, reassurance, go back to moving. They must move, they must exercise. When they exercise and they move, you give back all your rangsangan, all your information back to the brain to balance back again, so that it can go back to being automatically run. Lastly is to desensitize. The more you move, you tell them, you don't lion, you will not fall. The more you move, you desensitize, you habituate, you will actually lose that feeling of I'm not balanced. Doesn't make them so scared anymore. Okay. The other thing is cognitive. All that counseling is part of the cognitive behavioral therapy. Understanding, not giving in to the fear, and because I do DAS, so my DAS scoring, if it's very high, if usually their stress, anxiety is very high, depression not so much, I will refer to psychiatry. Okay, never work alone. Always work as a team, right? So if you find that okay, you do look like you have generalized anxiety disorder, go and see psychiatry. Sometimes the medication can help you tie it over. You may say, why not just send to psychiatry straight away and no need to see ENT. I've had patients who already under psychiatry follow-up on medication, it's not better. After seeing and going through all this, understanding, exercising, he stopped his medication and he discharged from psychiatry. Okay, so it can work both ways. So that is chronic. But it's not so, majority is 3PD, but there are many other diagnoses which can give you chronic ones also, which is another lecture.
Any final questions? No? Thank you very much, Ms.
Thank you.
Karen.